books, writes Hindi stories which are quite popular, column in newspaper, editor at Spirit and Harmony. Welcome Dr. Usha Banga. And next, Dr. Mahendra Jain is MBBS MD DM Neonatology from KEM Hospital, Mumbai. He is presently Director of Neonatal Pediatric Services at Sagar Multi-Specialty Hospital, Bhopal. Past affiliations, you can see here so many: ex-associate professor, Department of Neonatology, AIMS, Bhopal, NNF Secretary, State Chapter, Rajasthan, Joint Secretary, NNF MP, Organizer Secretary, Raj Pedicon, Organizer Secretary, West Zone, Newcon, 2019, etc. Sorry. You can read here. It is on display. His areas of interest: kangaroo mother care, delivery room care, ventilation, research and publications, 16 publications in national and international journals, chapters in textbook of neonatology. So this is about our panelists today. So let us start with the topic.
This is integration of research with clinical practice, and most important is welfare of the patient. Patients who receive evidence-based medicine care, they experience 28% better outcome. It has been proved in several studies. So we must keep this in mind. There is a huge gap between these two, which is a cause of concern. Many people say in practice, madam, it is not possible, patient want result, but you can see results are there. Now, something about the history. In 1970, by Dr. Archie Cochrane, patient, but it was being used widely in 1992. He is called the father of evidence-based medicine. Now, everyone says there are so many hurdles. I think Dr. Jain will discuss more about this in detail, but I will talk about few. There is lack of interest, lack of confidence in clinical appraisal, difficulty in procuring, utilizing and interpreting computer-based research, non-cooperation of authorities and institutions, lack of time and workload, lack of mentors, lack of staff, which is helpful in our work. All of us have different type of populations to cater. We have uneducated people, we have low resources, newcomers have more responsibilities. They find it very difficult to do evidence-based medicine. Causes we all know. And one of the important causes is high cost of medical education and BPC. I will talk about all these hurdles. How can we overcome these hurdles? We have to combine our 3 points. We have to collect best research evidence, clinical expertise, and patient's value. Patient should be in the center of our practice. There are several models of doing evidence-based practice, but I find PICO model is easy to follow. In this we see patient and population which we cater, what is the problem, what intervention you want to do, what is the interest of patient, and we have to compare different studies which is best for the patient. And of course, we have to see outcome of our intervention. We should design our practice in such a way, we have to keep at least 15 to 30 minutes of non-negotiable research and review time every week. I don't think it will be very difficult to do. 30 minutes is nothing. We should treat it like a mandatory administrative task. And we should use standardized protocols, develop documents which are simple based on protocols for your most common patients. And again, patient values and circumstances we have to judge. Is it a platonic law which never occurs? Is it so? Why can't we do this? Is it impracticable? Let us see. What are the hurdles which I have discussed? One of the biggest hurdle is pharma and healthcare provider connivance. I am sorry to say this, but this is the reality. How to overcome? I always suggest my juniors and my colleagues, keep your fee sufficiently high. Charge your fee because you are a expert and you are giving your mind and your intelligence, your experience. Many times the public has become like they are in a habit of going to a cheaper doctor. फीस कम है, पहले पूछेंगे फीस कितनी, 200 रुपए, हाँ चले जाए. Then they will go and take medicines of 1,000 rupees. So we have to teach our public that this is what they do with who charge less. Means cheap doctor costs too much. It is costlier in the end. And poor health literacy. For this we can use IAP, parental guidelines, educative posters in clinic like fever is a friend, it fights disease, don't be panicked, and you don't have to aggressively reduce the fever. How fever helps in the fighting infection, we have to talk to all our patients. We have to depute some time for this. One more thing which I don't like much, this is health insurance. People fall in the trap, doctors fall in the trap of the insurance. Whenever they see, even in America it happens. If patient has high amount of insurance, they tend to do more investigations, more stay in the hospital, and they will choose expensive treatment rather than choosing the cheaper options. And they say that you have to admit the patient, then they will pay you your insurance. This is also, I don't know why they have done this. So we have to see what we are doing. Patient is not come for one time. He has to be treated in long run. So we should keep this in mind. We should not, uska wo pura khali nahi karna insurance. We don't have any system of monitoring our prescription of private practitioners. Even it is not possible in US, but in UK they have all the computerized hospitals and seniors check prescription of their juniors, and if they write unnecessary, their pay is cut or some punishment is given. This is not done in US also because they are again insurance-based health system, and we know they are suffering. If you are senior in your group, audit prescriptions of a junior. हमेशा उनको खुश नहीं रखना है. It's not कि वो बुरा मान जाएगा, ये हो जाएगा. We have to put your point forward. If you are senior in your group, or even with your colleagues, maintain cordial relations with your peers so that you can point out if they deviate from the protocol. अच्छे से आपस में बात करना है. We can tell them कि ये ठीक नहीं है, ये नहीं करते हैं आजकल. Now identify your pattern of patients. I think over the time all of us know what type of patients we are having, what population we have, whether they are poor, they are rich, male, female, more children, adult, like that. In my area, most of the time we have infections, pneumonias, diarrhea, hepatitis, asthma, prolonged fever, stomach ache, and convulsion disorder. So identify your pattern of your patients, then go for evidence-based medicine. You must have observed, whenever we investigate patients, even in indoor, I have seen only 5% of sepsis screen comes positive. Very few In OPD, if I do 20 patients test, only 1 or 2 have high count and high CRP, high polymorph. Are we over prescribing antibiotics? Yes. Most of the people's prescriptions have more than 70% there are antibiotics. First drug is antibiotic. We should look into this. Why we do this? Fear of. If something happens to the patient, डर लगता है कुछ हो जाएगा मरीज को तो हमें क्या होगा, हमारे पे केस हो जाएगा. Mind you, we all have a robust immune system. In Lady Hardinge Medical College, they are trying to use again ampicillin and micacin more in even a nursery, and they are getting good results. In US, they are using gentamicin still, although they do serum levels of gentamicin, but they use it. So, you have to see if your child is healthy, good growth, he is not anemic, his immune system is working fine, you can wait for giving any medicine or any antibiotic. Patient will go to some other doctor. Patient भाग जाएगा. नए लोगों को बहुत लगता है मैडम किसी के पास चला जाएगा. I tell you, patient never leaves you because you have not result is not there. बुखार ठीक नहीं हुआ, no. Most of the time they leave you because of your behavior, poor communication skills, environment of your hospital, staff of your hospital, how they treat you. That after that they leave you. They will not leave you if your patient's fever has not come down within 3 or 4 days. Now this child comes to me and the lady says the child is having fever for last 8 days. Now I am thinking what to write, how logically I write, evidence-based medicine, क्या लिखूँ इसको, हार्टिंग से बुखार है. My whole dream is shattered of doing evidence-based medicine or ethical practice. Because the patient puts a big bag of medicines, he has received all the highest antibiotics before coming to me. What do I do now? If this thing happens, like I am little senior, so my population is quite fixed and regularly they are coming to me. So most of the time they listen to me. When they come with this lot of medicines, I tell them, make a box, first aid box. Which box should have emergency medicines, antiemetics, ORS, paracetamol, antispasmodics, antihistaminics, cough syrups, and then I ask them to do video consultation. Or first aid, I teach them a little bit. Like his child is 2 years old, ask them to give paracetamol this much and antiemetic this much, and most important, I tell them to recognize danger signs when you have to rush to the doctor. It's not that your child is having fever just now and you have to rush to doctor. कुछ नहीं होगा ऐसे. And I tell them danger signs, all of us know. I tell them if your child is taking feeds well, sleeping well, passing urine, his respiration is okay, he's not pale, he's roaming here and there. Don't worry, nothing will happen. Now, everyone says, and all of us know, we should always write provisional diagnosis on your paper. Fever, diarrhea, ARI, viral, we advise some medicines. Even we justify. If you admit the patient, you can't justify. हाथ तोड़ने की दवा पेशेंट्स को मैं बोलती हूँ पाउडर वाली दवा मैं बोलती हूँ ये कभी नहीं लेना है छोटे डॉक्टर से. Avoid taking injections from unqualified doctors.
Sorry, Dr. Usha, you have 10 minutes and Dr. Sir has 10 minutes and 10 minutes is for debate and my expert. So please expedite.
Just. Teach about harms of these drugs. And health literacy, we can do it very easily. Educated people understand better. DPCA is one hurdle. They keep medicines in the Price Drug Control Act. then people, doctor and pharma both lose interest, and even medicine which is effective is not available. We can put posters and everything we have seen. But remember, if society suffers, we all will suffer. There are some agencies we help, they help in EBP, they have Government Center for Evidence-Based Guidelines and all these agencies. This is the final thought. 95% health is catered by private practitioners. If EBP is not possible in private practice, then why the hell they are doing researches and collecting data? EBP is not a luxury for private practice, but a necessity for ethical, high quality and competitive care. We should mind that treatment can be done even without drugs. Drug is not always necessary. Thank you.
Thank you so much. Very nicely put forward your views. I
Not competitive evidence-based medicine with private practice, and it is true also. Let's see with few examples why evidence-based medicine will not work. Because it has limited applicability. Clinical trial often exclude certain population like elderly, pregnant women, make it hard to generalize finding. Even that the most of the drug that we can see that the pediatric population is excluded, and against we have to do these. So these are the most vulnerable population like elderly and pregnant women, but these are come in the exclusion criteria. As we know that each and every thesis, meta-analysis, they have inclusion criteria and exclusion criteria. Now I want to tell with one of my example why probiotics matter to the preterm infants. This is given to me, and then I go through the evidence exactly what is evidence was there in this. So these are the question: the preterm baby are having the high risk of NEC and late onset sepsis and having the feeding intolerance. And we need to which is the most things is needed, which baby is required. This extreme preterm baby are having the more problems with this. And we know that the probiotics, it decreases NEC, it decreases mortality, and it reduces late onset sepsis. It improves feeding intolerance and shorter hospital stay. It means that probiotics should be work in a preterm baby. So there are so many mechanisms that we can see in NEC. It's that it work probiotics, and this is the meta-analysis was there, and it's very recently meta-analysis 2005. So there is a lot of study are there since 1998 to 2023. Still we are in a research mode, and then we find out in this 50 studies, almost 52 studies are there, and 50% NEC can be reduced by giving probiotics in a preterm babies. Against sepsis, there is so many mechanisms in a preterm babies that it works against sepsis. So any sepsis, almost 18% can be decreased, relative risk is 0.83, and bacterial sepsis almost 18% decrease, and fungal sepsis, if we see, almost 60% can be reduced late onset sepsis. And then I become very happy that I should be used probiotics in preterm infants. But then I read it carefully. Then I found that in extreme low birth weight baby, this probiotics does not work. It is not decrease late onset sepsis. Then I worried that I should be used or not used. Then I think I should go more in a study about extreme low birth weight baby. And I found one more research, effectiveness and risk of preterm baby in preterm infants. And this was the one of a study that is showing it is the probiotics in the, there are two cohorts are there. One is the 34 weeks and the other is the less than 1 kg baby cohort is there. So this is the basically Canadian network, and 33 Canadian network it worked. And in this study, they took the two cohorts, and one was their outcome was the death, NEC and late onset sepsis. So in the both cohort, and death was decreased with probiotics, but there is no results, no conclusion against NEC and late onset sepsis. Then I thought that initially that I was, when I read that it decreased death, but it also decreased NEC and late onset sepsis. Then what happened in this study? I was more confused than what I should do. Then I go through in the detail this study, and there were the two arms was there, and I found that the no babies included less than 27 weeks baby, where that the NEC is the more problematic, where the late onset sepsis is the more problematic, but this is not excluded. These are the excluded, not the included, all these extreme low birth weight baby. Then I go that one of a more meta-analysis, and it found that there are 20,000 baby, they have taken the 63 studies, risk benefit ratio is calculated, and they found that 62 NEC and 42 deaths we can be decreased by the probiotics if we are using probiotics. If not using that, the death can be happened with the probiotics. So ultimately what death has happened in this extremely low birth weight baby, there were only two deaths. One death, it is because of it basically recovered from probiotic sepsis but died due to the unrelated cardiac condition. Other death was there, the developed right inguinal tenderness and redness is progressed to multi-organ dysfunction, failure and death in the nesting. So basically if we see that the probiotics, it causes, it is not rigorously that investigated in extreme low birth weight baby. So this was one of updates come in this AAP, American Academy of Pediatrics, and it says that in a recent warning from US FDA authority regarding the probiotic supplements following death of the extreme low birth weight baby subsequent to the probiotics related deaths increase the uncertainty of the probiotics, especially extremely low birth weight baby. So this is like a karna crust that the where that we should be use probiotics, but because the evidence-based medicine it does not have sufficient evidence, we cannot use probiotics in this extremely low birth weight baby. So this one of a limitation of the extremely low birth in evidence-based medicine, that the most vulnerable population is often excluded in this RCTs, and this second is that the over reliance on the guidelines. As madam told that the protocols are there, so strict protocols may undermine the clinical judgment and individual care. So that you can see here. So basically see one of my example, RDs and surfactant, and this is the protocol based approach. So we can see here that the patient with the RDS, we should give labor room CPAP, FiO2 less than 40%, then continue with the CPAP in an ICU. If FiO2 more than 40%, then intubate, give surfactant, short ventilation and extubate. This is the protocol. But suppose that the baby is still not responding, then what to do? Then this on go in the more protocol, then repeat surfactant, baby is not responding, then what you will do? You will ventilate baby, optimize ventilation, but is still not responding. Then what to do? Because now the protocol is not available in a RDS, what exactly we have to do. So basically, protocol is discouraging critical thinking. Rigid adherence to the protocol can lead to the practitioner to treat newborn as a uniform group rather than individual with the unique circumstances. This one size fit all mentality can prevent a caregiver for considering factors that fall outside the standard pathway. So like a rigid one size fit all approach usually ends up fitting no one. So then we start our thinking, then what could be the possible things are there in a preterm baby. It could be a PDA, baby is not responding. It could be a early onset sepsis, baby need antibiotic, air leaks, it can be air leaks. It could be a interface is not properly applied, suddenly oxygen supply is gone, and the secretions are there, that's why this is not working. So taking a one protocol, evidence-based medicine effectively, go with this example. This is the protocol for management of shock in newborn. So basically there are two groups are there. In the first group, this is the clinical group, Other group is the eco-based group. So eco-based group, that it means we require echocardiography machine. Even in the clinical group also we require echocardiography machine because we have to rule out PDA. So it requires lot of money for arranging, and each and every setup this echo machine is not available. Then what to do? That we should be stop treating shock in a newborn baby because we are having protocol that we should have echocardiography machine and that particular protocol. Now second, that setup, this is the one of a protocol, and this is the PPHN treatment. In PPHN treatment, first drug, it is the inhaled nitric oxide. Most of the setup, inhaled nitric oxide is not available. Second, it requires ECMO. So what should we do? What we should we do? So that I am trying to say that we are treating shock, we are treating in a newborn PPHN without all these things. So that if we are going to the evidence-based medicine, that means if achieving particular results we need that particular equipments and all these things are there, but it's not available. Now this is the last leg in the evidence updates. So research takes time, guidelines may not reflect in the most current situation. This is the Cochrane logo, this is that madam told that the father of evidence-based medicine was the Cochrane. The logo that you can see in the pink line, this is the one of first Cochrane review did in the antenatal steroids. So you can see in the antenatal steroid that the first study, Liggins and Hobby, they did in the 1972, and they proved that the RDS and the death can be prevented with the antenatal steroids. But over the years that it cannot be started till 1994, once that the Cochrane review itself did a meta-analysis on that, then only that the antenatal steroid was started. But still in the 2015, you can see in this ACT trial was there. There are again more and more queries were there in this. In the paper they have published on the, this is the multicentric study was there. But over the time with the thinking and rethinking and then the experience that come, antenatal steroid now in our protocol that we should be using the preterm baby. Last, it is the complexity of the integration. Balancing evidence with the patient preference and clinical expertise can be challenging. One of our examples is the cough syrup versus assurance. If we are going to assure a patient that the patient will not be listening, go to the another counter. They want cough syrup. So this is the one of our ethical issue also, and it is the basic. It is basically one of a challenge also. Antibiotic versus investigation. Patient do not want to prick their child. They say they start antibiotics, and then lot of steroids that in a sick baby we are using lot of steroids, but they have the specific protocols are there.
Dr. Minji,
Yeah.
sorry, your time is nearing its end.
Last. So thank you very much. So there is a lot of limitations are there evidence-based medicine. And the practical that we can have the backbone like evidence-based medicine, but the experience matters over the evidence-based medicine. Thank you very much.
So that's why we have to depend on guidelines, or rather we have to, in my opinion, we should take support from both our textbooks and our own research, making a balanced combination. Or just depending on our intuitions कि हम तो ऐसे देते हैं, हम तो 20 साल से वैसे दे रहे हैं, 10 साल से दे रहे हैं, हमारे पेशेंट ठीक हो रहे हैं, उसमें तो उसके थ्रू तो काम नहीं चल सकता. We have to take some guidance.
Agree, sir. Even we all use evidence-based practice in our practice, but as there is some, as I have to told against that, that's why, and even there is some limitations are there.
Your thorough disclosures of those critical and critical neonatal situations, a normal practitioner does not go into so many details. They just follow the guidelines. Dr. Usha has to say something.
The examples which you quoted, they are not very common things. Since you are working in a tertiary hospitals, there you can see guidelines or you can use your experience, but that is a very rare condition and it's very uncommon. But in during day-to-day practice, general practice, everyone is not doing tertiary care, even ICU care. But I am talking about day-to-day treatments like treatment of infections, anemias and many other things. In that case we can follow guidelines and that will be very easy for us. Mind you, EBP is very easy.
वेरी इजी एंड ये बात सही है कि आप बाहर पेशेंट का लोड है, आप 50 पेशेंट देखते हैं, 80 पेशेंट देखते हैं, आपके पास टाइम नहीं है और हर थोड़ा सा ऐसी सिचुएशन आने पे आप लैपटॉप खोल के बैठ जाते हैं, गाइडलाइन देख लीजिए, वो भी पॉसिबल नहीं है। तो आपको अपने कुछ प्रोटोकॉल्स बना के रखने पड़ते हैं जो आप देख सकें, या टेक्स्ट बुक को रेफर करें। पर टेक्स्ट बुक में हमेशा सॉल्यूशंस नहीं होते, कई सिचुएशंस के सॉल्यूशंस टेक्स्ट बुक में नहीं मिलते हैं, तो आपको लेटेस्ट गाइडलाइंस रिसर्च देखनी पड़ती है।
WHO, UNICEF, IAP, they are giving guidelines, good videos. If patient is not very serious, we can ask the patient to come tomorrow, do tests and read it. Even I do when some rare condition comes, I ask the patient to sit and take some BP and I go through the videos and protocol, then I make prescription.
मुझे लगता है 80% सॉल्यूशंस आ जाते हैं, लेकिन इनकी बात भी सही है कि बहुत सारी रिसर्चेस फ्लॉड हैं, फ्लॉड विद फ्लॉस, और उसमें भी बहुत डिस्क्रिपेंसीज हैं एंड दे आर नॉट एग्रीइंग विद ईच अदर। द रिसर्चर सबके अलग अलग रिजल्ट भी आते हैं, तो हमेशा उस पर डिपेंड नहीं कर सकती। यू आर राइट देयर। आप डॉक्टर सीरस।
Sir, I think we need to find a balance. We in practice can never go completely on evidence based. In this regard, I like to agree with Dr. Mahendra. How much time we rely and get the culture done in case of UTI, and how much antibiotics we do prescribe, as rightly been said by Madam. 70% of prescriptions are having antibiotics. Not to name anyone, but most of the leading hospitals, private practitioners, they are writing not only one, writing number of antibiotics, and we all know that. So is it evidence based? Many of us are writing cough suppressant and expectorant on one prescription. Is it evidence based? Many of us are writing Combiprate or ibugesic combination drugs. Is it evidence based? So I think we need to have a balance. That is the crux of the issue.
There are guidelines for clinical.
Guideline protocol give a framework to you, but your brain and mind and your analysis, this is the very important, and we learn from evidence also support. Thank you.
Experience-based medicine have to marry and live happily ever after.
Thank you, sir.